In this presentation, we're going to talk about caring for respiratory emergencies. Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder First on Scene for our Emergency Medical Responder course. We do not get paid to use this book. However, over the years, this course has worked to be easiest for our students to comprehend. Therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess students' learning process. The content on this website has been made available for our instructors to copy and distribute to the students in our classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocols supersede any education you learned in this course. You must also review with your medical director before changing your treatment plans that are outside your local protocol. We will review respiratory anatomy and physiology, define the following terms of accessory muscles, agonal respirations, asthma, bronchitis, and chronic obstructive pulmonary disease, also known as COPD. Define what cyanosis, dyspnea, emphysema, hypercarbia, hyperventilation, and hypoxia. Define respiratory compromise, respiratory distress, respiratory failure, tripod position, and wheezing. Explain the common causes of respiratory compromise. Describe the signs and symptoms of a patient experiencing respiratory compromise, and explain the pathophysiology of respiratory compromise. Describe the appropriate assessment and care for a patient experiencing respiratory compromise. Demonstrate the ability to appropriately assess and care for a patient experiencing respiratory compromise. Recognize the fear that a respiratory emergency can cause, and value the importance of reassurance when caring for a patient with a respiratory emergency. In this section, we're going to talk about the overview of the respiratory anatomy. We're going to do a quick overview of the respiratory anatomy. I think that was back in chapter 4 that we had talked about anatomy and stuff. So the respiratory drive, remember, is controlled by the respiratory control center found in the brain's medulla, and that controls the rate and the volume. Remember, the upper airway has the nasopharynx, which is the pathway for the oxygen in the upper throat from the nose to the mouth. And then the oropharynx, which is the pathway for the oxygen in the throat from the mouth to the larynx, which is where the vocal cords are, which separates the structure of the upper and the lower airway. Then you have the lower airway, which has the trachea, which is the oxygen pathway from the larynx to the lungs, and then the carina, where the trachea splits into the right and the left main stem bronchi. The lower airway also has the bronchioles, which is the smallest oxygen pathway in the lungs, and then the alveoli, which is where the oxygen and the carbon dioxide exchange. Here is an overview of the respiratory system. This should be in your book, or I'm sure you can find this on Google. In this section, we're going to talk about respiratory compromise. Anytime an individual experiences a condition that affects his or her ability to breathe adequately is referred to as respiratory compromise. Respiratory compromise can be the result of a trauma or medical condition that can come on suddenly or develop slowly over time. When breathing becomes compromised, the patient is unable to receive an adequate supply of oxygen. If left untreated, this could lead to a condition known as hypoxia. Hypoxia occurs when the body's cells do not receive an adequate supply of oxygen. Signs of hypoxia include altered mental status, pale skin, and cyanosis of the lips and the nail beds. Breathing can also become compromised due to inadequate ventilations. Ventilations become inadequate when they become too shallow or too weak, or when the air becomes trapped in the lower airways, such as from emphysema or asthma. As the ventilatory rate drops, a condition known as hypercarbia can develop. Hypercarbia is the condition of having too much carbon dioxide in the blood. Respiratory distress, also known as dyspnea, is the body's normal response to not getting an adequate supply of oxygen and an abnormal increase in the levels of carbon dioxide in the blood. It is characterized by an increased work of breathing, which is the amount of energy required to breathe in and out. An increased work of breathing is characterized by an elevated respiratory rate, the use of accessory muscles to expand and contract the chest, and an upright, often in a tripod posture of the patient, and the patient's inability to speak in complete sentences. In most cases, it is easy to spot a patient in respiratory distress because you can see that he or she has an increased work of breathing. If the cause of the respiratory compromise is not corrected, it can lead to respiratory failure. Respiratory failure occurs when the body's normal compensatory mechanism fails. The breathing rate slows, and the tidal volume gets shallower. The patient in respiratory failure will almost always have an altered mental status. If it's not corrected, the respiratory failure will quickly lead to respiratory arrest and possibly death. While there are many reasons a patient may experience respiratory compromise, a few of the more common causes that you are likely to encounter as an EMR include hyperventilation, asthma, chronic bronchitis, emphysema, traumatic injury, pneumonia, pulmonary edema, exposure to poisonings, and allergic reactions. Adequate breathing is breathing that is sufficient to support life. It is easy and effortless. The diaphragm, the primary muscle of respiration, gently and smoothly moves down as we breathe in and upward as we breathe out. Adequate breathing is characterized by normal respiratory or ventilatory rate, depth, and very little effort to breathe. Breathing should not be hard. One should be able to speak in full sentences without having to catch their breath. Here you will see respiratory compromise. They've got an oxygen machine at home, the way it looks. The normal breathing rate is the respiratory rate for adults is 12 to 20 per minute. Child is 18 to 30 per minute. Infant is 24 to 40 per minute. And the newborn is 30 to 60 per minute. Normal breathing includes that tidal volume, which is that amount of air in each respiration. It's not too shallow and it's not too deep. That's when you want to monitor the rise and fall of the chest. With normal breathing, the normal limits are 10 to 30 breaths per minute for an adult. The average range is 12 to 20. The respiratory rate can be as high as 60 for a newborn and steadily decrease with age. Normal depth of tidal volume. Normal breaths are not too shallow and not too deep. Your best indicator is an obvious rise and fall of the chest and or abdomen with each breath. With the work of breathing has to do with how much effort it takes for the patient to move each breath in and out. Normal respirations are effortless and unlabored, and as the diaphragm muscles move up and down with each breath. Normal ranges for infants and children will vary significantly by age, with pulses and breathing rates being fast at birth and gradually slowing down as age increases until they stabilize in their early teens. Along with assessing the depth, and the work of breathing, you must also assess the rhythm of the patient's breathing. The respiratory rhythm should be regular. Breaths should occur at regular intervals and last the same amount of time. Exhaling or breathing out should take about twice as long as it is for an inhaling or breathing in. Inadequate breathing, also known as abnormal breathing, is breathing that is not sufficient to support life. If left untreated, such a condition will eventually result in death. For most patients, the most obvious early sign of inadequate breathing is an increase in the work of breathing. In other words, breathing will appear labored and difficult. This is often called respiratory distress. If the patient does not receive prompt treatment, his or her condition can worsen quickly, and their body can no longer work to breathe. This is referred to as respiratory failure and is characterized by decreased respiratory effort and altered mental status. Common signs of inadequate breathing include increased work of breathing, increased respiratory rate, which is an early sign, decreased respiratory rate, which is a late sign, respirations that are too deep or too shallow, irregular breathing, and audible breaths such as gurgling, snoring, or wheezing. Just to recap, abnormal breathing is the increased respiratory rate, which is an early sign, or the decreased respiratory rate, which is a late sign. Again, abnormal breathing, the respirations that are too deep or too shallow, they may be irregular breathing rhythms, and they'll have audible breath sounds, such as gurgling, snoring, and wheezing. When breathing becomes difficult, the patient may have to work extra hard to move air in and out of his or her lungs. Labored breathing is usually obvious because the patient will be sitting upright, mouth open, and struggling to breathe. Someone experiencing dyspnea often maintains what is known as a tripod position. This is a position in which he or she is seated or standing with the hands on the knees, shoulders arched upward, and head forward. This position allows for unrestricted movement of the muscles used for the respiration. Other muscles, such as those between the ribs, the intercostal, and those in the neck and the abdomen, begin to assist the diaphragm. They are called accessory muscles because they assist only when the diaphragm alone is not able to move enough air. It should be noted that during cardiac arrest, a patient may exhibit reflexive gasping breaths that are called agonal respirations. These gasping breaths, no matter how frequent, should not be considered a normal respiration. Other signs of abnormal breathing can be cyanosis of the nail beds and lips, altered mental status, and abnormal pulse rates. In this figure, you're going to see the signs and symptoms of respiratory compromise. Again, this can be found in your book. Chest trauma. Injuries to the chest, such as a blunt trauma or penetrating injury, can cause damage to the muscles and bones of the chest wall, making it difficult and painful for the patient to breathe, thus leading to inadequate breathing. Damage can also occur to the structures such as the lungs and trachea that may disrupt the normal exchange of gases, also leading to inadequate breathing. Bleeding can also occur inside the chest cavity, reducing the effectiveness of respirations. Pulmonary edema. The accumulation of fluid inside the lungs is known as pulmonary edema and is a common complication for many patients with a history of cardiac compromise. The presence of fluids in the lungs can be heard with a stethoscope, and in extreme cases can be heard without a stethoscope. It presents as a crackling sound each time the individual breathes in or out. Pneumonia is caused by an infection of one or both lungs and results in the accumulation of thick mucus called pus. The pus fills the alveoli and prevents the exchange of oxygen and carbon dioxide, resulting in respiratory compromise. Chronic obstructive pulmonary disease. It is a variety of respiratory conditions and can be classified as COPD. Such conditions include chronic bronchitis and emphysema. The signs and symptoms of COPD may include a history of heavy cigarette use, persistent cough, chronic shortness of breath, pierced lip breathing, maintaining a tripod position, fatigue, tightness in the chest, wheezing, and barrel chest. In advanced cases, there may be altered mental status, barrel chest appearances, a strong desire to remain sitting even while sleeping, and a pale or bluish discoloration of the skin, lips, and nail beds. Bronchitis is a disease process that causes swelling and thickening of the walls of the bronchi and bronchioles. In addition to swelling of the tissues, bronchitis causes an overproduction of mucus in the airway passages. Both of these conditions causes the airways to become restricted, resulting in difficulty breathing for the patient. Some people have a condition called chronic bronchitis. Chronic bronchitis is defined as the productive cough that continues for 3 consecutive months and occurs for at least 2 consecutive years. Classic signs and symptoms of chronic bronchitis include overweight, mild to moderate shortness of breath, pale complexion, productive cough, and wheezing. Emphysema is most often associated with cigarette smoking. Emphysema is a disease of the lungs that causes permanent damage to the alveoli. Emphysema is also common in individuals who have been exposed to environmental toxins over a long period of time, such as coal miners. Emphysema causes the destruction of the alveoli, making them useless for the exchange of oxygen and carbon dioxide. In addition, it causes the lungs to become less elastic, causing carbon dioxide to become trapped. The loss of lung elasticity and the resulting accumulation of air caused by the chest wall to expand over time. This is often described as barrel chest appearance. Another classic sign of the patient with emphysema is what is called pierced lip breathing. The patient will hold his or her lips tight while forcing the exhaled air out. This increases the exhalation phase and causes a back pressure deep within the lungs, which is believed to assist with keeping the alveoli open, promoting that gas exchange. Wheezes are another common sign in COPD patients and can sometimes be heard without a stethoscope, which is also considered audible wheezing. The majority of emphysema patients are middle-aged and older and spend most of their energy just trying to breathe. Common signs and symptoms of emphysema include moderate to severe shortness of breath, very thin in appearance, large chest or the barrel chest, non-productive cough, extended exhalations, pierced lip breathing, and also wheezing. In this figure, you're going to see how emphysema affects the alveoli and bronchitis affects the bronchioles. Asthma is a reactive airway disease that affects millions of people in the United States. Asthma is a disease of the lower airway caused by increased sensitivity or the reaction to a variety of irritants such as pollen, pollutants, and even exercise. When exposed to these irritants, the bronchioles spasm and constrict. Once irritated, they also swell and produce excess mucus. These factors all contribute to making the airway passages smaller, resulting in an acute onset of respiratory distress. The narrowing of the airway passages will often cause the presence of wheezing. Wheezing is that high-pitched whistling sound that is created when air passes through the narrowed airways. It is most often heard when the lungs are auscultated with a stethoscope. In extreme cases, wheezing can be heard without a stethoscope. Most individuals with asthma have a few or no symptoms between acute attacks. Asthma patients often carry medication in the form of a metered dose inhaler that they can breathe into their lungs and when they feel an asthma attack coming on. The medications are called bronchodilators because they dilate the bronchial passages to help make them breathe easier. However, if left untreated, asthma attacks can be severe enough to cause respiratory arrest and even death. In this figure, you'll see that asthma causes the bronchioles to narrow and fill with mucus. The signs and symptoms of asthma include moderate to severe shortness of breath, wheezing, anxiety, and a non-productive cough. Here is one example of a metered dose inhaler. Here's a metered dose inhaler with a spacer. Hyperventilation syndrome. Normal breathing can be affected by emotional response or a sudden onset of anxiety. When this happens, breathing often becomes rapid, deep, and difficult to control. The body needs a proper balance of both oxygen and carbon dioxide. Hyperventilation occurs when the individual breathes out and eliminates an excessive amount of carbon dioxide. Most cases of hyperventilation are caused by anxiety and do not represent a true medical emergency. However, other medical conditions such as a blockage of the artery in the lung or a pulmonary embolism and an overdosing on certain drugs can also cause hyperventilation. These are considered true emergencies. In some instances, hyperventilation can be a sign of something more serious, such as an impending heart attack or other serious medical condition. Obviously, they've already activated the EMS system, so now it's your turn to provide care for respiratory distress. You want to be alert for the cyanosis and other signs and symptoms of inadequate breathing. Monitor that patient for changes in vital signs, which may indicate a serious medical problem. Regardless of underlying causes, your priority in the care of these patients is to reduce the anxiety by reassuring and comforting them. Though hyperventilation is rarely life-threatening, it can be very frightening for patients. They have a feeling of not being able to breathe, and is often that makes that situation even worse. They may also be caused by a serious medical emergency such as a myocardial infarction or a heart attack. Signs and symptoms of common anxiety-driven hyperventilation include moderate to severe shortness of breath, anxiety, numbness or tingling of the fingertips, lips, and/or toes, dizziness and spasms of the fingers and toes, and chest discomfort. The pulse ox is a simple tool that can be used to assess how much oxygen is getting to the patient's blood. It is most commonly placed on the finger, and through technology it can read the level of oxygen saturations in that patient's blood. A normal range for oxygen saturations is between 94 and 99%. And just remember that is on the cells that are healthy and alive. If you've got a carbon monoxide poisoning and 10% of your cells have been overcome by carbon monoxide, and your oxygen level is reading at, or your O2 stat is reading at 100%, really your oxygen level is at 90%, because remember the carbon monoxide is taking up 10% of those cells that you had. So it's only reading on the living cells. So 100% of the living cells have oxygen. However, 10% of carbon monoxide, or 10% of the cells have been overcome by carbon monoxide. So now that patient's O2 level is actually only 90%. Hope I didn't totally confuse you there. Here's a pulse oximeter that will measure and display both the oxygen saturation and the pulse rate. Your assessment of the patient with respiratory compromise will begin as you enter the scene and first lay eyes on that patient. You must begin by observing his or her body language. Is he or she sitting, standing, or lying down? Does he or she appear to be conscious or unresponsive? Your assessment of an unresponsive patient will need to be much more aggressive than for a responsive patient. You must kneel beside the patient and place your ear next to his or her nose and mouth to confirm that he or she has a patent airway. You must also determine the characteristics of his or her breathing, their rate, the depth, and the work of breathing included. You must provide positive pressure ventilation if you determine the breathing is inadequate. When assessing a responsive patient, pay attention to the level of distress and facial expressions. Does he or she appear anxious and frightened? If so, the situation is likely getting worse. You want to introduce yourself and immediately begin to reassure that patient. Tell him or her that you are going to help them breathe easier. As you begin to gather a history about the patient's situation, pay attention to his or her ability to speak clearly in full sentences. One of the classic signs of moderate to severe distress is the inability to speak in full sentences. A patient in moderate to severe distress will be able to speak only in a few words before having to stop for a breath. Again, you want to gather that history and that ability to speak clear in full sentences. Then you're going to listen for sounds as he or she breathes. Noisy breathing is always a sign of some form of airway obstruction. It can sound like gurgling, which usually indicates a presence of fluid in the airway. If the sound is more like snoring, either the swelling of the upper airway or a partial blockage caused by the tongue may be that issue. The problem usually can be corrected with proper positioning of the head. So you want to confirm or establish an open airway, check the rate, the depth, and the work of breathing, provide positive pressure ventilation for inadequate breathing, and then a bag valve mask device that is placed firmly over the patient's face, and provide the rescue breaths at the right rate for the age of the patient. Here's an algorithm for emergency care of patients with respiratory distress. When breathing is inadequate and the patient is no longer alert, You want to provide positive pressure ventilations with a bag mask device. You're going to take appropriate BSI precautions, perform your primary assessment, and support the ABCs as necessary. You're going to ensure a patent airway and administer oxygen per your local protocols. Allow the patient to maintain a position of comfort and arrange for ALS response if it is available. Next, you're going to assist with the prescribed medication per your local protocol and medical direction. Obtain that vital signs and continue to monitor the patient and provide reassurance. So in this section, we'll go over what we learned. Respiratory compromise is one of the most common calls that we encounter. It's characterized by increased work of breathing, increased breathing rate, and use of accessory muscles. If left untreated, it can lead to respiratory failure, respiratory arrest, and death. Causes include asthma, bronchitis, emphysema, and hyperventilation. Asthma is a disease of the lower airways characterized by spasm and swelling of the bronchioles, resulting in narrowing of the airways. Triggered by allergies, dust, stress, and/or exercise. Bronchitis is an inflammation of the bronchi and the bronchioles. It results in overproduction of the mucus over the inside lining of the airways. It may last for months at a time and characterized by a productive cough. Emphysema is a loss of lung tissue elasticity and destruction of the alveoli. It results in poor gas exchange and trapping of excess carbon dioxide within the lungs. Slow progressive disease that results in severe respiratory distress. Hyperventilation syndrome is mostly associated with situations of high stress or anxiety. Begins with the stress of the situation, causes the patient to breathe fast. If not controlled, it will result in the loss of too much carbon dioxide. It's usually treated by helping patients calm down and control their breathing. Care includes support of the ABCs, providing supplemental oxygen, calming, and reassuring the patient. You want to allow the patient to maintain a position of comfort and do not force the patient to lie down unless they are unresponsive. Rapid transport by ALS ambulance is most appropriate care for severe emergencies. If available, you want to encourage to self-administer any prescribed meter-dosed inhalers as prescribed.